Welcome to the JOMA Preventative Health Podcast, hosted by the Jewish Orthodox Women's Medical Association. We provide you with up-to-date information on health topics geared towards the Orthodox Jewish community. This podcast content is provided for informational purposes only and is not intended as medical advice or as a substitute for the medical advice of a physician.
Welcome to the Jewish Orthodox Women's Medical Association, or JOMA podcast. I'm your host, Elisa Minkin. I'm a general pediatrician and proud JOMA member. And today I'm really honored and really excited to be here today with Deetza Franklin. Before I introduce Deetza, I'm going to repeat, please reach out to us at health, HEALTH, at joma.org if you have any comments on these talks. You want to be interviewed, you know someone who wants to be interviewed, you have a topic you want to hear, please reach out to us at health@joma.org. We want to hear from you. Deetza Franklin, LMHC, is a licensed mental health counselor and certified school counselor who has been working with children and families since 2008. She's passionate about social emotional learning, teaching children valuable life skills as a preventative rather than reactive measure. Deetza has recently launched a children's project entitled Real Feel Media, spelled REEL, Feel Media, which teaches children how to regulate their emotions through catchy songs that are culturally appropriate for the Orthodox Jewish community. In her private practice, in addition to working with children on emotional regulation, Deetza specializes in working with children with the diagnosis of selective mutism. These children struggle to speak in some settings, such as school. Deetza uses an intervention protocol developed by Dr. Stephen Kurtz. She has seen tremendous progress using this method and is eager to share these strategies with others to benefit as many children as possible. So we're going to put it in the show notes, but I want to give some websites. First of all, her website, www.skillfocusedtherapy.com, SKILLFOCUSED therapy.com. Her music website, and they actually have links on each website to each other. It is www.realfeelmedia.com, REELFEEL media.com. And we mentioned Dr. Kurtz. Dr. Kurtz has a website, which is amazing, called kurtzpsychology.com. That's KURTZ psychology.com. And also an amazing resource for selective mutism is the Selective Mutism Association, which is at selectivemutism.org. Welcome, Deetza. Thank you so much for joining me today.
Yeah, thanks for having me.
Yeah, I'm really excited to discuss. I'm excited to discuss your music. I am. We're going to get to it, but I'm actually super excited to discuss selective mutism, which not everybody is aware of. I suspect that it's underdiagnosed. So I really would like to talk about that. I first want to start with some definitions. Let's talk about what selective mutism is and what it is not, please.
Yeah, okay. Thanks so much again for having me. So selective mutism is an anxiety disorder. It's very closely related to social anxiety. And basically it's when a child who can speak comfortably and normally in one setting, which is usually home, cannot speak in another setting, which is usually school. And they would get the diagnosis after a month of not speaking in this other setting. So typically it's when a child starts school that, the teachers will notice they're not talking in school. Some kids, it just takes them a few days or weeks, but if it persists after a month, that's when they would get the diagnosis. It's usually pretty clear cut, but the complexity comes when there's comorbidities, there's other diagnoses mixed in. So a lot of times a child will get the diagnosis of selective mutism first, because that's the more obvious one. And then once they're able to be tested further, it might, they might have some other things going on at the same time.
Right, exactly. But if you look at a child who's selectively mute, right, and you don't necessarily know how well, for example, they're talking at home, it might look like something else, right? I do want to talk a little bit what it could look like to the outsider.
Yes. So I think one of the most common myths is people a lot of times jump to thinking there was abuse or trauma. Mm-hmm. And that's really a big myth, because I think what they're mixing it up with is sometimes when kids are older and there's a trauma, they might like suddenly stop talking. That's a different thing. This is when the child starts school. It's present right away. And usually there's a very genetic component. Very, very frequently, there's a parent that has a similar, either had a similar thing as a child or is very, very quiet in social situations. So it's definitely based on anxiety. The other things people mix it up with is defiance. Oh, they're just trying to be difficult, and they're purposely not answering me. What are there some other things you're thinking of?
Autism. I'm thinking of autism because
Yeah.
I know that there's on these websites where they talk about selective mutism, they try to explain to you why it's not autism. Why would you think that even?
Okay, so some children with autism don't speak or have difficulty speaking. So I think that's where the mix-up comes in. But the difference is that a child with selective mutism, when they are fully comfortable, will speak normally, will make full eye contact, can have very normal social interactions with the people that they're very comfortable with. That's where the difference comes in.
Right. Also, when you say eye contact, it is common, correct me if I'm wrong, that kids with selective mutism do not necessarily make good eye contact.
Correct.
Not at home necessarily, but when they're in that setting, for whatever reason.
Right. So it's really a fear response. So people call it like the deer in the headlights or fight or flight response, where they're just like frozen, kind of like in shock, where, if someone's in the street and they see a car coming. That's the kind of look you get from the child with selective mutism when they're asked a question, because they're just like their anxiety peaks. So yeah, they're scared to make eye contact in those situations. So someone with autism would have difficulty with social interactions in other ways, the ability to connect, the ability to understand social cues, things like that. So with selective mutism, it's coming from anxiety. It's not coming from a lack of social skills. So it's just a different.
Right. I mean, to be fair, I think that they overlap more than the Selective Mutism Society is giving out. I do think so, because I think that for a lot of people on the spectrum, they do have anxiety often when they're aware enough that they're behind socially. And so it may really overlap more. They may have mutism in public spaces because they're aware that they don't know the social norms, or they don't fully understand, or other things. And that leads me to when you talk a little bit more about the comorbidity or co-associated conditions with selective mutism.
Yeah. So it's interesting that you say that, because I see this a lot with kids who have other reasons why they're not feeling as confident with speaking. So one very, very common one is children who are bilingual. So they're speaking one language at home and a different language in school. So they are aware that they're behind on their language skills, and that they maybe are coming out not sounding as smooth as other children. Even I'm talking about children who actually can speak the language. So, I mean, one of the things when you make the diagnosis is, if they don't know the language, that's not called selective mutism. That would rule out selective mutism if they just can't speak the language at all. But I'm talking about children who can speak enough to communicate, but they're self-conscious. So the other thing is kids who, let's say, have some kind of speech impediment, stuttering or whatever it is that makes them self-conscious. So when that's coupled with a little bit of an anxious personality and perfectionist tendencies, where they want to make sure things come out sounding just right. So I've actually seen that a lot with kids that I work with. I would say the majority of them either have a speech issue or are bilingual and are perfectionists. So it makes sense when you think about it. They know it's not coming out perfect. So they're especially self-conscious.
Right. And I know we talked about this before, and I haven't been able to find a lot of data on it, but I do wonder about the connection with language processing and auditory processing. It makes sense also if you were having more trouble, particularly in a group setting or with, more complex speech interactions in a school setting, that you might shut down. Again, along with an anxious personality, it might appear differently. Say you might have more of an ADHD picture if you weren't as anxious. I'm just throwing it out there. This is not evidence-based. I'm sorry. I just think it's more complex, and I just want to throw the complexity out there so that we don't oversimplify it.
Yes.
And the oppositionality, I was reading, is actually not an uncommon trait. So I could see why people might think the child's oppositional, because they could have that as part of their personality too. No?
So it's interesting. I've been seeing this with some of my clients recently, especially the older ones. So with the younger kids, when you start pushing them, which we'll talk about, how to, push them along to start speaking, they get very scared, and eventually they try to do it. But some of the older kids, they get to it, they get angry. This I have this now. I'm like, wow, this is something different. It's like, wait, you're pushing me to do something that I'm uncomfortable about. And then sometimes there is a little bit of that oppositional, like, I don't want to do the thing you're pushing me to do that's so uncomfortable for me. So that's part of the work sometimes, is trying to get them on board with the goals. But yeah, you're right. People are very, very complex, and there's so many things mixed in. But just for the purpose of defining it, the actual definition, like, speaks at home and not in school, that part,
that's the easy part.
Simple. That's the simple part. Right.
Right. And I'm sure, you see a wide spectrum of it, where some kids just straightforward have classic selective mutism, and you can do your approach and they do great. And other kids are more complex, and you're going to need to look deeper into it, which we talked about. Like, it makes sense to start with the approach for selective mutism. And then if they're not making expected improvement, start digging deeper. I think you have to do a huge investigation, starting with the diagnosis.
I think there's a little more to it, which is, regardless of whatever else is going on, the approach that we use is pretty effective. So you can get a child to a point where they're answering and they're speaking a little bit, and then you could start to get to know them, and you could start to deal with everything else. I feel like it's almost like a basis. I mean, being able to speak in public is like part of functioning, know? So it's, what I like about this approach is that it really is very effective, even if they're dealing with other things. So
right.
Help them. Yeah.
Right. I didn't mean to interrupt you, but also, I just want to point out that you told me yesterday, and you're 100% right, that if a child isn't talking, you can't test them.
Exactly. Yeah.
So you're going to have to wait till they're willing to speak to you to get accurate testing anyway, and speak well enough.
Yeah. Yeah. I have had that with kids with like complex learning issues. So yeah, until they're able to speak to the person doing the evaluation, they're not going to get accurate results.
Right. Absolutely. And I do want to point out, you kind of alluded to it, that it's not selective mutism if it's a child who doesn't speak English. Also, the picture of a child much later in life suddenly stopping speaking after a trauma. It used to be called elective mutism because it was thought to be the child's choice, and it was thought to be after a trauma. And now we know that there's this picture we're talking about. So just want to clarify, this didn't get into the DSM-5 to the DSM in the DSM-5 until 2013. It's really been thought about differently over time. And it's really like less than 10 years that we're thinking about this as a subset of anxiety disorder, and not an emotional disorder that you need therapy, psychodynamic therapy for. So I think that's really important. And that means that the things we talked about earlier, some of the things that could be associated with it or underlying it, may exist more often, but we don't know because the literature is just too new. Yeah. I think. So we talked about other things that could be associated with. Who would make the diagnosis?
So because it is a mental health related thing, anyone who can make any mental health diagnosis, a psychologist, a social worker, a mental health counselor, frequently a pediatrician will send someone to a therapist, will say, I think this sounds like selective mutism. I think what's unique about this is that most therapists are not trained in treatment of this, and it's very different than typical therapy. So, if a child goes to a therapist and meets in the office once a week, it might be nice for their self-esteem. It might, if they get to a point where they're speaking to the therapist, it might be helpful to them. But if the therapist is not specifically trained in treating selective mutism, it's not going to carry over into helping them speak. So that's just an important piece, that whoever identifies it should point the person in the direction of, this sounds like selective mutism, go look it up, go find a therapist who knows about this. There's a website called SMA, the Selective Mutism Association. So it has a list of treating providers. that's where a lot of people start once they are pointed in that direction.
Yeah, I looked up Florida where you practice, and you are one of only 4 in the entire state of Florida on their list.
4? There used to be 8. I don't know what
There's
happened to the
4,
other 4.
and only 2 are in Miami. So
Oh my gosh.
you know, and that's why it's so incredible to have you on, because you're not just someone who's read about it, you know, in the ivory tower. You're someone who, you know, for whatever reason took an interest. And, you know, we talked before, it wasn't really that, you know, you have a family member or anything. You just found a niche that you're interested in and at this point really good at.
I think I was very moved by, as a school counselor, I had a number of students. Actually, one of my very first students in my internship in 2008, I've worked with a bunch over the years, and there's something very rewarding, like when the child feels so trapped. It's interesting because teachers will say to me, like, do they want to talk? Do they realize they're not talking? And I say to them, like, are you kidding? That's all they think about all day is like, how come I can't, you know, sometimes no one talks to them about it, but it's going through their mind, like, why don't I talk? Why when I want to, like, I'm trying to open my mouth, nothing's coming out, you know? So when they're helped and they're able to speak, the joy, like, is so palpable. It's just, I find it very, very rewarding.
That's awesome. And just thinking about it, if you send them to a therapist who does not have this particular therapy, there's a good chance they won't say a word there.
That once what?
They won't say a word. It's quite possible they won't say a word. And like you said, even if they do, it doesn't mean that it will generalize, because it's not a psychodynamic problem, right? It's not.
Right. I do think that, you know, an empathetic therapist is likely, if they're very patient and they, you know, just make them comfortable, that after a bunch of sessions, they might start speak. I mean, every child's different. Some people, it's in that setting, they feel safer. So, you know, they might speak, but that wouldn't surprise me so much if they're able to speak to the therapist. But yeah, the carrying it over part, how to help them bring that into school or wherever they're having the most trouble. That's the part where this approach is very unique.
Right. We're going to get to that in a few minutes. Yeah. What age do you normally pick it up? I mean, you kind of mentioned, you say it's usually picked up at school age.
Yeah. So it's interesting. I've been getting calls like younger and younger, like, and a couple calls this year of like 2.5-year-olds, but I usually don't start working with them until age 3. I think under age 3, there's a reasonable chance that they'll overcome it, maybe just with a little bit of prompting. But once they're around age 3, that's when it starts becoming a more noticeable problem, really.
I'm impressed that you say under 3 you're getting calls, because I read 3 to 8, and 3 being the lower limit. I mean, kids up to 3, a lot of them aren't really talking so much. How do you even know?
Yeah. So the people who have called me, I think the reason they're alarmed is they say, my child is so verbal at home, you know, and they're not speaking in school. But more typically, I think that probably the average age is 5. I think, you know, typically when they're 4, the parents are like, oh, maybe they'll outgrow it, not really sure what it is, you know, and by the time they're 5, they're like, we should probably do something about this. But I get people in elementary school, middle schools, it just gets harder as the years go on. We'll talk about that. But it gets reinforced if it's not treated. So it gets harder to treat once they're older.
I saw on some website, they said selective mutism is outgrown. I was so surprised by that. Is that true?
No.
All right. It isn't, right?
I was taught that it's the majority of the cases, it will get reinforced. It will be harder to overcome, and it's unlikely to be overcome on its own. However, it could be that some adults naturally use some of the things we're going to talk about, and that could help a child overcome it. Also, I think in preschool, I've seen kids overcome it without any kind of support in preschool when it wasn't going on as long. But once a kid is like in elementary school and has already been not answering questions, not speaking for a number of years, I think it becomes much less likely that they're going to be able to overcome it without some kind of help.
Right. I mean, if you think about the youngest kids, 2, 3, 4 years old, who may be starting school for the first time, they may just be anxious about separation, and that may be causing them not to speak. And that's not the same as selective mutism, which is why they may be supposedly outgrowing it, because they never had it to begin with, which is the problem, by the way, trying to jump the gun too soon.
Yeah, I think it's very typical for a kid the first month or even two of school. Actually, I've had this conversation with a number of parents. In the Jewish schools, you don't have a straight month of school at the beginning of the school year, because you have this yontiv, then they're home for a week. So for a child like that, every time they come back, it's like a whole new transition all over again. So I would say wait until you have a straight month of school before, which really is like 2.5, 3 months into the school year, before you say like, okay, maybe this child really could use some intervention.
Right. Okay. I'm ready to talk about the intervention.
Yes.
Let's go.
Okay. So just to add a little more about anxiety. So the way anxiety works is when a person is exposed to something that they fear, their body, reacts with fight or flight, their heart rate goes up and all those uncomfortable sensations. But the amazing thing about anxiety is that it peaks and it gets really uncomfortable. And then at some point that peak, I'm very visual. I always think of like that graph, it goes up and then it goes back down. So, anything a person is scared of elevators, if they go on an elevator for 2 hours, it'll peak. And at some point it's going to go back down. Like we're just wired to not stay on that level of anxiety long-term. So that's really the idea of exposure, is when you face your fear, it gets very, very uncomfortable and then it goes back down. So what happens with when a child has something that they're very afraid of, so, we could use any example, but let's say like a dog is running down the street. I've seen this all the time. A dog is running down the street, the 3-year-old starts crying and like clutching their mother. And so very typical parental response is like, I want to protect my child, and they're scared. So I'll pick them up, or I'll say, oh, we're going to go far away from the dog. Or if we're at someone's house, lock up the dog, we don't have it out when we're there. It's like, I'm going to keep you safe so that you're not near a dog. So the parent feels like I'm protecting my child. But what happens is the child's anxiety goes down because they were rescued from the thing they were afraid of. And what that does is it creates a reinforcement, which we'll call negative reinforcement, which is, oh, when I see a dog, I need to be rescued. Once I am rescued, I'll feel better. So the next time I see a dog, I am going to need to be rescued so that I could feel better. So that's the negative reinforcement. When we rescue a child from something they're anxious about, it reinforces the anxiety. So, and I mean, I've done this so many times as a parent. I think that it's just human nature. Like we don't want to see our child crying and scared. And it's like, I'm here to protect you. But so this is where it's like not so natural. It's something that sometimes we have to teach ourselves. But the flip side is the child sees the thing they're afraid of, let's say the dog. And instead of immediately picking up the child, the parent could say like, oh, you feel so scared, but it's really a nice doggy. It's, it's not going to hurt you, whatever it is. Let's say that the parent does not immediately pick up the child and the dog comes a little closer, that kind of thing. What ends up happening is the more the child faces the thing that they're afraid of, the more that peak of anxiety that I was describing, they get very scared and then it goes back down and they're like, oh, I'm still okay. It's actually not dangerous. I can handle this. And then the next time they see a dog, that was positive reinforcement. And now it's like, oh, I could handle this. And their anxiety is going to be lower the next time. So how does this work with speech? So with selective mutism, what happens is that the trigger is getting asked a question. So the child gets asked a question, they freeze up, they get the deer in the headlights look. And the important thing to note is that it's not just the child who gets anxious, everyone else gets anxious too. And I've seen this so many times. All the adults, especially loving, caring adults, teachers, parents who really want to help the child, they get anxious because they're like, what do I do for this child? It's so uncomfortable. They're so frozen. So human nature is a lot of times someone will jump in and rescue. And you see this in so many ways. Either they'll be like, oh, she's shy. I'll just tell you her name. Or what starts happening in schools once the other kids pick up on it is I've seen this many times, like as a school counselor, I'll walk into a class, they'll say, oh, she doesn't talk, and the other kids, it's so sweet because they're trying to help, but they'll say like, oh, just point or just write it down or just nod your head. The other kids are like trying to help the child to communicate nonverbally, which they think they're helping, but it's actually, you can use the word enabling or
I have to say that the little enablers.
They're rescuing the child. So the child, it becomes reinforced. Like, okay, when I get really scared when I'm asked a question, I need someone to rescue me, and then my anxiety will go down. So the flip side of that is when they're asked a question, to not rescue them and to give them some silence, and we'll talk about, there's a lot of different ways to try to prompt them and push them to be able to give a response. And then once they give a response, their anxiety goes down. Everyone's anxiety goes down. And that's the positive reinforcement, is like, oh, I could answer. I did answer. When I do answer, my anxiety goes down. I feel better. So that's really what we want to accomplish. And the other really important thing, especially if anyone made it this far in the podcast, the first thing you have to know, if nothing else, is don't ask questions until you're ready to like push and try to get an answer out of them. You have to like retrain yourself to not shower this child with questions, because now that I'm into this, I see that we just, as adults, we just like throw question after question. Do you want do you want to tell me? I don't know. We just throw questions at kids, and they don't answer all of them, and we don't think twice about it. But for these children, if you're going to ask a question, you're going to push for an answer. If you're not going to push for an answer, do not ask the question, because that creates negative reinforcement. So, it's better to not ask the child a question the entire day of school and ask them one question that you're going to push for an answer. And they will go home knowing, when my teacher asked me one question today, I successfully answered. As opposed to, my teacher asked me 15 questions today and I only answered one, and I didn't answer 14. That's 14 negative reinforcements. So that's what we were talking about age. Children that have been dealing with this for longer, the hundreds of thousands of questions that they have not answered over that time has created a lot of negative reinforcement. And there's actually another thing to throw in here, which is they call contamination, which is, so we were talking about this a little bit. There's a little bit of a similarity to OCD in terms of it being like a very rigid way of, the anxiety creates these like rigid rules. So it's like these children, it's not a mistake, meaning they're very, very aware of what the rules are. So it's like, I do talk to this one if they're like past the front gate of the school. A lot of parents tell me this, right when they exit the front gate of the school, the kid starts like, it's like a switch. They just start chatting. It's not by mistake. It's very clear in the child's mind. Like, I will speak in this spot. I won't speak in that spot. I will speak to this child. I won't speak to that child. So what happens with contamination is once they're asked questions and they're not answering, that person becomes quote unquote contaminated. So it's like, this is one of those people that I don't talk to in school. So, they might have an easier time speaking to the cashier at the supermarket than they will to their teacher who they've had for 9 months, who's loving and caring and kind. And teachers sometimes get insulted and they say like, I don't understand. I poured my heart and soul into this child, and like they're talking to the cashier. But it's not personal. It's that same concept of like, you're contaminated because you're in the classroom. She's been unsuccessful speaking in your class, for a while. So now it's going to be that much harder for her to begin speaking in a contaminated space. It's not impossible. It is definitely possible. It's just a little harder. So just like rule number 1 is try to not ask if you're meeting a child for the first time. And I actually think in general with young children, if you want to make a connection with the young child, it's always a good practice to not shower them with questions. Just smile at them, let them warm up, give them some space. Sometimes don't be in their face. A lot of kids benefit from that. And then they gradually get more comfortable and they're more ready.
Right. This is amazing. I wasn't going to talk about my daughter, but I'm going to talk about her for just 2 minutes, because otherwise
Please.
People are like, how does she know about this as much? And that's because my daughter with autism also has selective mutism. And we didn't say before that they could be associated, and you won't read about it in the literature because they're talking so much about how it's not the same thing. And it's not to be confused with autism, but yeah, apparently it can be, because she has both. And she always will say, make them stop, they're in my face. This concept of contamination, I get it. I want to go over it a little bit more because it sounds oppositional, or it sounds like almost
Right.
delusional. And it really is a word we're using to explain what happens when somebody has already triggered the anxiety response from the get-go.
Yes.
That's why the cashier is still kosher and the teacher is not.
Right.
Because whenever the person sees the teacher who's in their face all the time, they automatically have the anxiety ramping up, whereas the cashier may have intuitively not been pushing them.
Or, well, I think some of this is where I was saying similarly to OCD, some of it is place, some of it is person, and some of it is place. So for some children, the place of school is contaminated.
Mm-hmm.
So if, for example, if they're in their classroom or if they're in the hallway, actually, I was telling you as an intern when I really didn't know that much what I was doing, but I tried, I did my homework, but the child that I worked with, she spoke to me a ton in my office. The second we walked into the hallway of school, she, like, her demeanor changed. She stiffened up. Her eyes got that like big scared look.
You're in a headlight, yeah.
Yeah, but even if no one else was there, it was the location. So there's the contamination to the location also. So I'm just saying the cashier is not in school.
Mm-hmm.
And some children, everyone's different and everyone's rules are different. So I keep hearing more and more, like, some kids, they'll be able to speak to a woman faster than they'll be able to speak to a man. Some, they'll speak to a man faster than a woman. Some, they'll speak to kids faster than adults. Some the other way. Like, every child is different. But the point is that once they had some negative reinforcement in school, so for example, let's say it's a new school year and they have a new teacher. If they meet that teacher the first day of school in the classroom with 25 other students, it's right away, they're already, even before the teacher makes any mistakes of asking a question, they associate that teacher as, oh my gosh, this is the person in school who's going to, like, this is my place where I struggle. So one of the keys to starting off on the right foot is to try to have the teacher meet the child outside of the first day of school, either in a quiet classroom or maybe even in the child's house, or, so the location helps a lot too. But then also the person themselves, like we said, I think of it as like throwing a ball. You want them to catch every ball. If you throw 6 balls at them, they're not going to, and people do this all the time, but what's your name? Oh, as soon as they see a little hesitation, they'll just throw another question. So for these children, the key is, if you throw a question at them and you're seeing they're struggling, I'll go through exactly what to do, but like, it's kind of like you take 2 steps back. Okay, I'm not going to ask anything else until we have success with one question.
Right. This is great. And I just wanted to reinforce, I'm going to say it right, because on the OCD talk, I said it wrong. I said neurons that wire together, fire together. And I meant neurons that fire together, wire together, meaning that the more you repeat an experience, the more your brain wires that way. And that's why early intervention is so important, and waiting longer makes it harder to treat. But I think that also underlies what we're calling contamination, what we're calling the rules. It sounds so oppositional. And I just want to take away that misconception that this is all trying to dampen anxiety. If your experience is, in this school, I have anxiety, and your response to that is, though I will not talk, that's why you're doing it. It's because of the social anxiety.
I think also it's important to add that they truly feel like it's impossible. I'm saying the fight, flight, or freeze response. So, you're in the woods, you're in the woods and you see a bear and you find that your feet cannot move off the floor. That is your body's, adrenaline response to a danger where you physically cannot move. So that's what it feels like to them. They want to speak, they want to be successful in answering, and they feel so frozen that, like, sometimes you even see them like trying to move their lips and like it's not coming out. And that's, I think I just mentioned this before, but that's why it surprises me when teachers say, like, oh, she realizes she can't speak. And they're so aware, and they feel so badly about it,
So let's talk about the actual treatment.
Yes. Okay. So Stephen Kurtz created this thing called PCIT-SM. So PCIT is parent-child interaction therapy, which is basically a pretty behavioral therapeutic method where the therapist teaches parents certain skills to connect with their children in a positive way that reinforces positive behavior. So he kind of took that idea and you know, changed around a little to meet the needs of a child with selective mutism. So I think the main point of the connection skills is what we've just been talking about, is that before you can start working on speech, the child needs to warm up. Their anxiety has to go down. They need to feel like comfortable. So we break it into 3 skills. One is behavioral description. So, you know, you meet a child who has trouble speaking. So you try to connect with them by making a lot of comments on what they're doing. Oh, I see you're putting that over there. Cool. You know, wow, you're whatever it is. You try to, you know, build some point of connection just by commenting on what they're doing and leaving out any of the questions. Then there's labeled praise, very specific praise about whatever they're doing, and reflection, which once they do say something, you always follow up by repeating the words to them and then following with a labeled praise, like a compliment. Wow, I love how you told me that. Or, you know, I loved hearing your brave voice. Some people like using the word brave to teach the idea of facing your fear. So these are kind of like warm-up skills. So anytime I work with a child, I spend a while in this stage before I'm going to even attempt any questions. But even let's say a teacher who has had success getting a child to speak, any new interaction, you always start with some of this. So the child walks into the room, you know, a typical parent thing to do is, oh, say hello to your teacher. So that's like absolutely off the table. Do not, you know, we don't tell them to say hi. We don't tell them to tell us anything right when they walk in a room. At first, it's just, you know, the comments. Oh, I love your backpack today. It's so pretty. I see you're hanging it up right away. Awesome. Just comments, but no questions. That's the PCIT, you know, the warm up part. And anytime a child is getting stuck with speech, you always go back to these skills. You know, that's the backing up from asking questions. Okay, so but the part I'm sure people want to really know is, how do we actually get the speech? So it's a gradual exposure intervention. So we try to break down like what's the easiest possible way for them to speak in any form. And we're going to push them to do that thing. We talked about the idea of a ladder, where it's sometimes people find it helpful to even like write out the ladder of like the bottom of the ladder is going to be saying one word to the teacher outside of school. I don't know. That would be the easiest, let's say, thing. And then a little bit up the ladder would be saying one word to that teacher in the hallway outside of the classroom, you know, and then one word to the teacher in the doorway of the classroom, and then more than one word, you know, then you could raise the level of like what kind of questions, what they're saying. So actually one of the easiest ways for many of these kids is something called a fade in, which is where they get overheard. It's really amazing how effective this is. I think because there's so much fear of choosing to speak when they know someone's watching them, and they are so hyper aware of who's watching. You see their eyes like moving around. They're like, is anyone looking at me before I speak?
Okay. It's a very self-consciousness. It's not simply a social phobia. I'll say something stupid, but you're looking at me. Right?
Yeah. So a fade in is basically the new person, let's say the teacher, is outside of the room, and the familiar person, let's say the parent, is in the room with the child and doing a lot of these CDI skills, which I was just describing, you know, warm up, and then some very basic questions where the new adult is outside, slowly hearing, slowly getting closer, maybe popping in the room, pretending to not notice them, face her back to them, just get something and go in and out. And when you do it for long enough, the child, you know, they're more comfortable, and they, I guess, forget to have their guard up to not speak in front of that person. And once they realize the person already overheard them, it's so much easier, because it's like that person already knows I talk. They already heard my voice. They're not going to have that like shock reaction. That's one of the things they really fear, is the people who are already contaminated are going to have like a big shocked what? She talks. I can't believe it.
But that can happen though, right? I mean, you might think that the right thing to do is to make a huge, big deal of it. Like when the child's toilet training, yay, we made it in the potty, yay, she spoke, right? And you're saying that could be actually counterproductive.
So a little bit of praise is great, but having all the attention in the room on them could make them a lot more anxious. And especially a child who, let's say the other kids in class are all like, what? She's talking, By the way, I keep saying she just because it's easier, but there's plenty of boys with selective mutism too, although for some reason it happens to be more common in girls.
It makes sense to me. I want to go back a little bit and just have you clearly explain a basic hierarchy, because you're kind of alluding to when you talk about fading, where the child is spontaneously talking, but not to the person they're being overheard, versus spontaneously, talking.
Yeah, wait. So before we get to that, actually, I want to just go through how it looks when you ask the child a question.
Okay.
And we'll go to the higher levels. So there's something they call it VDI, verbal directed interaction. So this is the sequence that you would use when trying to ask very, very simple questions, which, like I said, would probably start out in a fade-in kind of situation where the familiar adult is doing this and the new adult is only overhearing it. And eventually the new adult will be asking directly. But the way it goes is there's something called forced choice, which is basically multiple choice. So you give the child the options of the answer. What's your favorite color? Or what color would you like to use to color with? Blue, pink, or orange? And that makes it much, much easier for them when they have the words already fed to them. Okay, so you ask the question, the child gives the deer in headlights look. So the next thing to do is count to 5 in your head. So 5 full seconds of silence. And then ask again. Do you want blue, pink, or orange? Count to 5 again. Ask again. Count to 5 again. So it's officially up to 15 full seconds, which could feel long and painful.
Forever.
Yeah. But again, you're starting out small. So you would not do this in the middle of a busy classroom with 20 children staring at the child. Absolutely not. That would be terrible. The idea of this is in a quiet place where you feel like there's a reasonable chance they've already warmed up with this person. It's the bottom of the ladder. You think they might be ready for one question. That's where you're going to work on this. So it's the full 15 seconds. As you repeat the question, you could simplify it a little. So for example, do you like to color with green, pink, or orange? And then wait 5 seconds, then green, pink, or orange. Wait 5 seconds. So you kind of like shorten the answers as you do it to make it a little simpler. Another thing are yes or no questions. So some kids find yes or no easier to say. So for example, after you say green, pink, or orange, and they're not answering, the third time you might say, do you want pink? Yes or no? The problem with yes or no questions is that children with SM, many of them have learned to use nonverbals to communicate. So they're very likely to start nodding their head and shaking their head. When you're working on this skill with them, we want to break the habit of communicating with nonverbals. So anytime we ask a question, we want to push for a verbal response. So if they're shaking their head, nodding their head, or pointing, this is where I feel like I'm being so annoying, but I know that I'm helping the child. I say, I see you're nodding your head. Is that yes or no? Please tell me yes or no. So what happened? I know everyone's question is, okay, so you did this whole sequence, 15 seconds pass, they're still not answering. What do I do? Help. So basically, again, visualizing the ladder, you always go one step back on the ladder to what was the last place this child was successful speaking. And we're going to go back to that. But the first thing you say after the 15 seconds is, okay, I see you're not ready yet. We're going to practice and come back to it. And that's really key is I asked one question. I am going to come back to this question, hopefully today. That would be ideal. Like really, it should be the same day. If that child is successful speaking in some other ways, you could even try right then saying, okay, you know what? I see it's hard for you. Right, you don't even have to say this, but you could think to yourself, what is hard about this situation for them? There's too many people around. It's too noisy. It was too sudden, whatever it is. So you try to take it a step back. So for example, a teacher could take the child out of the classroom and ask again in the quiet hallway. Or let's say they have a friend that they do speak to, which is common. The teacher could say, go practice the answer with your friends, and I'll ask you again in a little while. Things like that. So the idea is we would like to make sure that they are successful answering this question. And the key is don't just jump to asking more questions. Tell yourself, I'm going back down the ladder. I am not asking any other questions right now. They're not ready. We'll go back to the child-directed interaction, warm-up stage, and we're going to get back to this question to have them be successful.
That is great. That is such a great explanation. And I want you to just really spell out that the levels that there are here so people can understand, because you keep saying, don't ask more questions. People have to understand that if it's too hard, pushing it over and over is going to make things worse, right?
It's really tricky. You had a line that you told me before. I'm trying to remember what it was.
The right hard.
The right hard. I love that. You do want to challenge them. And I find sometimes teachers, especially the really dedicated ones, it creates anxiety for everyone. They're like, I don't want to do the wrong thing. I don't want to push them too hard. I don't want to. The good news is, don't worry. You make a mistake once in a while. Nothing's irreversible. If you're continuing to try these things, you will have success with them, But the point is, you don't want to push too hard at the wrong time, but you also don't want to make the mistake of being scared to ever ask them a question and challenge them, because then they're not going to progress.
Right, not just that, but you don't want to be an enabler. There's a fine line between being an enabler and hitting them at the right hard.
Yeah, well, so in this situation, it's if they're asked a question and then people allow them to avoid. But the other thing I'm concerned about with these children in school is they're so quiet that they could get overlooked. Right. They need something. Some of these kids, if no one's going to come over to them and ask them, oh, is there something you need to ask me? They're less likely. So in terms of the hierarchy, things like initiating, going up to someone, starting a conversation, asking the teacher for help, that's like the highest end of the ladder. So a lot of kids I work with, we get to the point where they're able to successfully answer questions. I'll tell you, like, a typical trajectory is first they speak to the teacher during the fade-in. Then the teacher will start asking them 2 questions a day in the hallway. Then the teacher will start asking them 2 questions a day in the classroom. Then the teacher is able to ask them those 2 questions with another kid kind of eavesdropping. Then we'll start pulling in, they're able to whisper to 3 kids in the class. So in terms of how long it takes, that's where every child is so different. Some kids, once they overcome that contamination and they're like, oh, everyone knows that I could speak to them, they make pretty quick progress. Some kids, it's still a very slow going up the ladder. We have to keep helping them. Okay, so they're what happens frequently is kids get very comfortable. Like, I speak to these 3 kids and I speak to these 2 teachers when they ask me in the corner only. If we don't keep moving them along, some of these kids will stay there, and those will be the rules, So we want to keep breaking the rules and keep saying, okay, you spoke to those 3. Now we're going to have a 4th kid who's joining your table, and we're going to do easy questions and activities that prompt speech in front of another person. We want to keep raising it. So I work with some kids where they've mostly overcome the selective mutism, but they're still really struggling with the social anxiety aspect. So even though you ask them a question, they will answer, they're still very frozen in social situations. Let's say recess, everyone's running around. The child will just sit there like they don't know, like, who do I go up to? What do I say to them? And again, it's not because of a lack of social skills. It's because they're so frozen with anxiety. So we use like pretty similar approaches of exposure, like, okay, what could you say to join, who do you want to play with? Those people. Okay. What do you think you could say to them to join in? Sometimes they need the practice and the prompting from an adult to break the ice of like, okay, I could go over to them and speak to them.
Right.
I feel like there's just so much to say. I don't know.
No. Or they could have social skills deficits that you're only seeing now, right?
100%.
Underlying their anxiety.
Yes, exactly. We're not ruling out social issues, right. But I'm just saying the fact that a child with social anxiety could appear
right.
to have a lack in social skills when they don't. There's a chance that they have both. That is true.
Right. I mean, we keep saying that selective mutism is a subcategory of anxiety, specifically social anxiety and social phobia. So it makes sense that if you've gotten rid of that, what's almost a specific phobia of speaking in public places, there will be other components in this child's personality, maybe to be more behaviorally, and socially inhibited. So that's something to keep in mind. Just for the selective mutism, how long does this therapy take?
Yeah. So it's, in terms of therapy, so I was taught something that I like, which is that it's good for parents to think of this as an exposure lifestyle. And the truth is, I think even with any kind of anxiety treatment, it's important to know that if your nature, if you have anxious tendencies, which are very common, it's important to know, like, this is a part of myself. This is something that's with me for life. And I can learn to navigate it and manage it and work with it, but it will pop up. You're not like fixing it and making it disappear. So in the case of selective mutism, there are kids that, they'll get to a point with a lot of parent and teacher support and a therapy, therapist coaching everybody, where they're doing great, but in a new situation, they might be frozen again. When meeting new people in a new class, a new transition, some parents will, once they're trained by the therapist, some parents every year at the beginning of the school year, they'll ask the teachers, can we have a meeting before the first day just to help the child warm up? So really, I think that the most effective way to do this therapy is for the parents to get a lot of training, and they have to really be their child's advocate. In new situations, if there's a stranger that comes up to them and starts asking 100 questions, the parent has to be an kind of like an air traffic controller, where sometimes you have to literally tell other people, like, how about just ask her one question, right? How about ask her what's her favorite color? Sometimes you have to help people along to set things up for success for the child. So in terms of the actual therapy, it varies so much. Every single child is so different. There are some kids that will have, let's say a couple of months, and once they get to that point where they're speaking to their classmates and their teachers, they kind of take off running. There are those, but I think they're more the exceptions. Many of the children will struggle with, social anxiety, and it could be years of dealing with it, but with increasing progress, or occasional setbacks, it's really, really hard to answer.
Right. I have two takeaways or points I want to bring out. One is how important the parent's role here.
Yes.
Right. Because whether you're done with official therapy or you have ongoing, the parent makes a huge difference. You're like the air traffic controller. That's a really hard job, by the way. That's number one. And the other thought that I had is that not all kids will respond to therapy because they might have such a profound level of anxiety that they require medication. So we really need to talk about the role.
I was literally thinking
we must talk about the role of medication, please.
Yes. I just want to say one more thing about parents. So I think I read somewhere 95% of these children have a parent who had selective mutism as a child. I might have gotten my statistic wrong, but it's
that doesn't make sense.
It is a high number of
I think social anxiety is very common.
Or who had significant social anxiety or, something related to that. So it really is a very hard thing for the parent of the child, because of course, everyone wants the best for their child, but frequently the parent is a little on the quieter side. And, as a therapist, I'm asking them, make play dates, call up other parents and say, can we have a play date where I'm there and I'm prompting and I'm, or the therapist is there and prompting, and it's uncomfortable. Also, the parent has to be able to explain to people. I had someone tell me they took their child to like a ranch they thought it would be therapeutic. And basically one of the instructors started screaming at her child for not answering, that she thought she was being rude. So it was the opposite of therapeutic. It was very, very upsetting for everyone involved. And the mother said she was so shocked. She was like tongue tied. But so I was trying to coach her, it's so hard, but really the parent's role is to say, excuse me, my child has, maybe even before the situation happens, just please be aware, my child has this thing called selective mutism. It's not, it's not defiance. It's very uncomfortable. The parent has to really put themselves out there. But I find, I guess the encouraging part is people are really respectful and helpful when you explain to them what you need. I think most people want to help and they're just clueless sometimes. So, I'm saying we all want to know how to help people and what to do. And like, I know for myself, if someone comes over to me and says like, this is what this person's going to need, just a heads up, of course I want to help them, So I think people really appreciate being
heads up
told in advance. Yeah. So there's a lot of that for parents to do, which could be, it could be really challenging.
Right. And again, I've said this in so many related topics that when a parent has anxiety or another mental health issue, taking care of themselves is also a way to take care of their child. And one of the best ways to take care of their child is to take care of themselves. You can't help your child properly if you have your own crippling anxiety, or you feel your child's discomfort too much because you haven't overcome your own. So I think that's a really important part of this for any of these anxiety disorders.
Yeah, I think I'm like a little, I think it's really important to say that we're not pointing fingers at parents.
No, not blame.
I feel like parents, again, like the trauma myth, a lot of times people look at the parents like, what is going on in your house that you're like, I've actually heard people say, 2 or 3 or 4 kids in one family with selective mutism, like something must be going on. Actually, no, it's genetic.
Right.
It makes sense. It makes sense. There is a genetic component to it. So I'm just saying parents, I've seen such incredible parents who work so hard with their children to help them. And we're not pointing fingers, but it's just becoming aware of what your own role is with your child and how it's going to help.
Yeah, no, I don't want this to come off at all. Chas v'shalom as blaming. It's the other way around, is that to give yourself the grace that if you need help, you will be helping yourself and your child. Right? Yes. That's true for any of these anxiety disorders. I've talked about it like a trillion times on related podcasts. It's not blaming it all. It's understanding that component, right? That parents just want their children to be happy and comfortable. And if you are anxious about your own anxiety / your child's anxiety, you may unintentionally have too hard a time to help them. That's what I'm saying. Yes. It should not be coming across as blaming at all.
Yes. Okay. Yeah, I just wanted to.
I want to clarify. I'm glad that you said that, because I'm so anti, parent shaming and blaming. If it comes across like that, that would be terrible. I don't want that to happen. So I'm glad that you pushed me on that. I hope it's clear. I hope it's clear.
So about medication, I think medication could play a huge, huge role in treatment. I actually was just looking at some of the links that you shared with me, and one of the topics, it said, the child shouldn't have to work so hard or something like that. So yeah, for some of these kids, every word, every answer is, a full 15 agonizing seconds. It's such hard work. It's so painfully difficult, and medication could be such an incredible help. And I've seen this. I'm like, you're jump starting them, by lowering their anxiety. Their ability to overcome this will be for the child where it's determined that it's a good idea. Like, it could really, really, really jumpstart their progress, make it much easier and much quicker. It could play a huge role.
Right. I mean, I'm going to put a couple thoughts out here. First of all, I think there's a lot of parents who are very fearful or against medication. And again, we're not making any recommendations here, but like you said, it can really help a child, and some children are not going to make progress or quickly enough without it. It doesn't mean they're going to be on it forever, but I also hate it when people say, oh, it's a crutch, it's a temporary thing, and then you'll get off it when you're better. We're talking about kids who are prone to anxiety. So they might need to be on that medication for the long term, not necessarily for selective mutism, but for other anxiety issues. Might. I'm just throwing it out there.
So I think that's an important point too. However, I think that for someone who has a lot of reasons why they're not comfortable with it, if if your child has already been getting treatment and its progress is not as quick as you would like, and it's, painfully slow and difficult, and it could be something to consider for the short term for selective mutism specifically, because those initial gains of speaking for the first time, and I have this right now with a child where the kids are, she talked? Did she talk? Did you hear her? Did she talk? And I'm trying to be the air traffic control. I'm like, shh, we're not talking about her. She's going to talk when she's ready, change the topic, stop staring. But people do have major reactions at the beginning. So that beginning step is the hardest for some of these kids. So to overcome that hurdle, I'm just saying, even if someone is opposed to being on it long-term,
right,
at least think about the short term, that it's something that might help your child overcome that initial hurdle. And once they're already speaking, even if for whatever reason, I'm not saying you should, but if you decide to take them off the medication, it could be pretty likely that they'll be able to maintain their gains and continue, even if the parent is not open to continuing the medication. It's just something to consider. I'm not saying someone should rush to go off of it,
right,
for
and they may not need it. They may truly not need it. I'm just throwing out all possibilities out there, because there is, in a lot of parents' minds, a bias against medication. And like you said, it can be a real game changer, either in the short term or in the long term, but it doesn't necessarily have to happen. I don't know what percentage of kids respond to therapy without, but again, I think you'd have to say it's individualized, and you couldn't make give a specific number.
Yeah, I think in general, as a therapist, I see a lot of people have this approach, which I think is reasonable, which is, let's try therapy first. If we're not making the gains that, we would expect to see or we would hope to see, then at that point, we could add on the medication. That's the approach I've seen many people take. The thing I want to mention with selective mutism is that medication alone is unlikely to be enough, because with the medication and an adult who has this kind of training to know how to ask simple questions and prompt them and build up gradually and push them to answer, there's a chance the child maybe their anxiety will go down, but that jump of going from not speaking to speaking is still might be too hard for them to do on their own.
Right, because you have to go through the whole hierarchy.
Yeah.
It's not going to happen just with the medication. I'm going to throw out the elephant in the room, which is that, unfortunately, it's so hard for people to access therapy, either financially or because of availability. I mean, you have a very specialized field here.
Yeah.
So what about the people who can't? What should they do?
So first of all, something I've been mentioning is I've discovered that insurance is more likely to get you specialized help than, because most insurances are, it's just something that people should know. Insurances are legally required to have providers who could provide your medical needs. So when it comes to something so specialized, you can fight insurance and say, you don't have any therapist in your network who can provide the therapy my child needs. They're not, none of them are trained in this. And then I've gotten single case agreements from insurance where they're paying like out of network rates, and if you push them enough, obviously insurance is always push back and hope that you will not fight with them, but eventually it is something that could be covered. That's just one thing. But another
That's a great point. That's a great point. Yeah.
Yeah. What'd you say?
Fight for it. I mean, I think all of this should be covered. It makes me so angry, but fight for it. And that's a good point that, precisely because of the lack of availability of that particular specialty, you might have a better chance of getting it covered.
Yeah. Yeah. The other thing is, because this intervention is so much about parent training and exposure, there's a lot that parents can do. There's free things you could see online. You can make yourself an expert even without tons of therapy. You can ask for meetings with teachers, educate them. For some people, I just act as a consultant where I do some trainings and how do we set the next goal? What should you do next? Another thing I want to mention is a lot of therapists who work with this do camps where it's a week intensive therapy camp where basically every child, and I went to 2 of them this summer. I learned so much. It was incredible. Every child is assigned their own therapist. and the entire day they're pushing them to speak. And they create situations where the child has to ask for ice cream and whatever it is. But, if you can, even if a child's not having like ongoing therapy, something like this, where they just have like intensive exposure, sometimes could also really springboard a lot of progress.
Right, that's a good point. But I like the idea of parents, becoming educated and advocating, and you also, have the right to have a 504 plan, even if you don't meet criteria for special education and have an IEP, an individualized educational plan. You can have a 504 plan, and that will be your child's legal rights to accommodations and modifications, and you can have that written up.
Yes, I want to jump in about that. The tricky part with accommodations is that once the child gets to the point on the hierarchy where we can push for speech, we don't want to allow nonverbals. But before they're at the point where they're able to communicate with their teachers, they need to be able to communicate nonverbal. They need to be able to get their needs met. So, for example, a very typical issue is the bathroom. If the child's not sure how to get permission to go to the bathroom, they could have an accident, and this happens and is very sad. That's like getting your basic needs met. So that's an accommodation that the teachers have to be aware of from the beginning. Tell the child, just go. For some kids, raising 2 fingers is too hard for them, things like those kind of accommodations are really important, because it really is a disability. Until they get to the point where they're able to express themselves, it really could be like a disability. And it's so sad if they're in a situation where they can't get their needs met. So, before they're at the point where they're beginning to speak, they really need those accommodations. Once they're starting to speak, you want to pull back some of those accommodations and not accept nonverbals.
Right. You don't want it to be an enabler in writing.
Right.
So I think that's true. I really want to give you a chance to talk about your music.
Oh.
I really do.
Can I just one more thing before that? Thank you.
We could talk about this forever. We're going to have to bring you back. I told you we're going to have to bring you back.
Thank you. I just want to throw out a couple troubleshooting ideas and tips for, if you are trying to get a child to speak and they're stuck. So there's a lot of different things you can try. So I think I mentioned some, like pulling them out of the room, taking them somewhere quiet, or having them practice with someone they already speak to. It sounds funny to say practice, saying what your favorite color is, but really to them, saying the word again and again, and what color do you like? Pink. What color do you like? Pink. Oh, great job. You practiced 3 times with me. Now so this is another thing. You might not even have to go out of the room. The familiar adult practices it with them a few times and then says, okay, now turn and tell that person, now that you told me. That's something you could use. Shaping, it's called shaping, behavioral idea, which you can also do that idea where you literally exit the room, that familiar adult practices, and then takes a step towards the new person. What's your favorite color? Pink. Great job. Now we're going to take a step over. What's your favorite color? Pink. Great job. Take a step over. What's your favorite color? Pink. Okay, now we're finally next to the person. Great job. Okay, now you're going to tell her. And at that point, they're just turning their head and repeating themselves. So it's that much easier. I use this all the time, and it's very, very effective. There's also, I didn't mention at all, but we use a lot of, token economy, rewards, charts. If it's, for some kids, talking about charts before creates anxiety. Everything is like a balancing act. But it's more like when they do speak, it's like you said before, we don't want to make a huge deal where they get self-conscious, but it's an understated, like, wow, that was awesome. I'm making 2 checks, whatever. And then they get that visual, I use a lot of prizes and parents buying them ice cream that night and things like that. I'm a big believer in it, because I think we use the word brave. Like, you're doing something that's hard for you and you're being brave and you're pushing yourself. And that's something to celebrate. And it's funny because you would think they have the internal motivation, like, of course they want to talk, but in that moment of fear, the idea that they're working towards an ice cream might speak louder to them than the fact that they really just want to speak. So it's a very useful tool. Just wanted to mention that.
Right. I want to make one more point, is that it shouldn't just be on the parent, it's on everybody that helps with the child. So you want to create a culture that knows what to do. And Dr. Kurtz has a great resource, Selective Mutism University, where anybody for free can take courses in it and really become, much more knowledgeable about it. So teachers, therapists, et cetera, should do that.
Yeah, I wanted to mention one other thing. So another thing is if they're frozen, is telling the other people in the room to look away. So it could be, oh, everybody, look, there's a train passing, or,
Right.
or a teacher could say, everyone go back to your worksheets. And then once the attention is off the child, or everybody practice with the person next to you, to do something so that people stop looking, because the child is extremely aware of people looking. But I've literally just said to a child who's sitting there staring, okay, look that way now. And they get it. So I just wanted to mention, I have a student, I just think it's the cutest thing. She has a best friend who's like, she's been watching me very closely. And this child who's like 8 years old started doing this for her friend. Like, she asks a friend a question and then she sees her freezing up and she'll say to the other kids, like, okay, look over there. But it's amazing to me that this 8-year-old is intuitive enough that she's like picking up the skills I'm using, and she's trying to help her friends. So really anyone can be a part of the process.
That's awesome. That's really awesome. But I want to give you a chance to talk about your music, and it's getting close to Shabbos.
Okay. Yeah, thank you. So basically, I did a lot of social emotional learning classes as a school counselor in a number of schools. And I noticed that they have songs and music videos, and the kids just love it and sing along. And even if they might not be like fully connecting with the ideas of the song yet, but they're singing it. And I feel like in a couple of years, there's a song from Second Step, Stop, Name Your Feeling, Calm Down. So, that's something that sticks in your head. So anyway, I just love the idea of music as a tool. And I wanted there to be more frum content, things that are culturally appropriate for frum people. So the project kind of evolved, but at this point it turned into a feelings music project where each song is a different feeling. And I happen to be very passionate about this as a therapist, that I used to work a lot more on coping skills. Like, okay, you're sad, you're angry, you're nervous. Okay, let's make a list of, you're going to play with your squishy and whatever you're going to do to calm down. But what I've gotten much more into over the years is the process of becoming very aware of your feeling is possibly about 2/3 of the calming down work. Once you validate yourself, acknowledge, like, this is the feeling, it's real, this is what's coming up for me, it's valid, it makes sense. I don't have to judge myself for having this feeling. I could be compassionate to myself for having this feeling. It has a name. It's a real thing. Once you do all that, already you'll feel yourself calming down. And then, yes, you could go do your coping strategies as well. But really the getting more in touch with your feelings is a huge piece of therapy and of anyone working on their emotion regulation. So these songs, the idea is that the song teaches what it means, what it feels like in your body. The mood of the songs and the music and everything helps kind of like capture the feeling. And I worked very hard that the message of the song, before we get to like, and what should you do with the feeling and how do you calm down and get rid of your anger or whatever it is first the validation of the feeling. So about half to 2/3 of the song is teaching about the feeling. And then most of the songs, like, towards the end, have some strategies for like, what do you do when you have this feeling to work with it? Because obviously we're all in control. We're all responsible for our actions and reactions and behaviors. Accepting your feeling doesn't mean you can therefore go do whatever you want. So that's the idea of the songs. Right now we have, the first 5 are available. Yeah. So there's a theme song, which teaches a lot of different feeling words in a fun way. And then the chorus is, the main line is, each feeling is so real and each one is okay to feel. That's kind of, I would say, like, captures what it's all about. But it's been a lot of fun and I really want kids to listen to it. I think it, again, like when you just have a song that you already know, then sometimes in the moment you might find it popping into your head, I've had people tell me that their kids use it, like they've used it with their children, especially the anger song. For some reason, kids find it fun and funny because it has some examples that they relate to. And it's a tool, that could really help kids to validate themselves. And I think when parents, it could also remind parents to use those kind of words with their children to validate. So I'm really excited about it, and I hope people get to listen to it.
Yes, we're linking to in the show notes to your real media, and I'm mentioning it in the I have mentioned it already apparently in the bio. But
okay, realfeelmedia.com.
Yeah,
and
I'm going to mention it. Yeah,
it's in the process of going on to Mostly Music also.
Oh.
And two of the songs are available on music platforms. So the Feelings theme song and the Anger song are available on Spotify and Apple and all your other music platforms.
I love that. I love that so much. And I love the idea that, would you say 2/3 of it is naming and validating?
That's the idea. It's a little different than me just.
That's wild. I think that's really amazing. And I think that that's kind of the newer approach that everybody's doing now, but not necessarily how we grew up. Right?
Yeah. I've been noticing, like, I, as an adult, find this stuff very helpful. Just, I've been noticing I shouldn't be jealous. I shouldn't be angry. I shouldn't, we beat ourselves up when we have a feeling. And yes, we want to work on the reaction and on dealing with the feeling. But like the first thing is, my gut is telling me this feeling in reaction to something. So this is an experience I'm having that's real. It's real for me. It's painful. It's difficult. And like when you let yourself, and you're just normalizing yourself, like, I'm a human being. So this is how it feels for me. And that's telling me something, it's a whole different world, because you're not fighting with yourself for being human. It's like, I'm accepting it, and now I can work on it. So jealousy, I put a lot of thought into the jealousy song, which is not out yet, but it's in progress. It's like, it's a real feeling. Someone has something that I desperately want, and I don't have it, and they do. It's really painful. It could be a really painful thing. But the Torah tells us not to be jealous, which means I do have to work on it. I have to work on getting myself to the right mindset. But I don't need to beat myself up for the fact that feeling came up for me.
Right.
So,
I think that's so important, because it's so easy for children to misunderstand. The Torah says, don't be jealous. I feel jealous. I'm bad.
Exactly.
Right. So you're giving them the tools, starting with, we all feel stuff.
Yeah.
It's what you do with what you feel.
Yeah. So I worked hard to figure out, like, what is the key to working on jealousy? Really, it's working on focusing on what you're grateful for. It's not beating yourself up and saying, I shouldn't be jealous. That doesn't work. But telling yourself, okay, I do feel jealous. That's a very real emotion for me right now. And I want to focus on being grateful. And I want to focus on that Hashem gives me what I need. And I want to focus and then you work on it, but that first feeling is valid. And also the other thing is having more than one feeling at the same time, similar thing. So for example, you're having a simcha and you feel sadness that someone's not there. So I feel like a lot of times you might get that, like, what's wrong with me? I should be happy right now. And I can't believe I'm thinking about that. But instead of fighting with yourself, you have like compassion for all your parts. This makes me think of IFS, internal family systems, whole other topic. But just
I did a podcast on that, by the way.
Okay, but that resonated with me, because it's like it's the compassion for all your parts. Whatever comes up, it's compassion. Like, yes, I feel so happy, and I feel sad because I wish that person was here, and that feeling is real, and my happiness is real. They don't have to compete with each other. And it takes the edge off when you're like, oh, like it's okay that I have these feelings, and then you automatically start feeling better, as opposed to when you fight yourself.
I love this. This is like, dialectical behavior therapy for kids. I hold two feelings opposite at the same time.
Exactly.
Right. I mean, and it's amazing, and it's good for grownups. You can sing it with the kids and learn as you go.
You should know that I find the songs helpful. There's a song like "Sad Feelings Are Okay, Tomorrow Will Be Another Day." Like, I find myself singing it to myself sometimes. It's good to remember.
I think that's so amazing. I mean, you go from strength to strength. It's so needed what you're doing. Both things, right? Your specialized therapy and selective mutism, right? And your music for everyone.
I just want to mention that I'm not musical. I love writing lyrics, but I have some amazing people that I've been working with that have all been working as a team to put together the different parts of it. And I'm not the singer, it's boy singers, so anyone can listen to it. I'm really grateful for the people who, the main ones are Mark Levine and Eliza Palgon, very, very talented. So
it's an awesome project. And like I said, it's in the show notes, it's in the intro. So I want to thank you so much for doing this with me, especially on a short Shabbos.
Thank you. I really appreciate you having me and appreciate the work you do. And I love listening to your podcast.
Thank you. Thank you so much.
Okay.
Have a good Shabbos.
Have a great Shabbos.
Thanks for listening to the JOMA Preventative Health Podcast. If you've enjoyed this, please rate and review us on Apple Podcasts and share this with your friends. For more information, check out our Instagram at JOMA_org. Check out our website, www.joma.org, that's JOWMA.org, or email us at health@joma.org.